So we have Keith here, Keith Harrigan, who's working with Mark Dretzy, who is not here because it seems that he's presenting, he's doing a presentation today somewhere else. But yeah, he's good. He's working with more people, more at the hospital, I think, I guess. So, well, you can introduce yourself a little bit too. And yeah, unless no one needed to say anything else, sorry, no one seems to have any topic. Okay, keep focused.
Thank you. Welcome Mark's Lab and then everyone else that I probably haven't met since COVID happened and I moved to New York. So I'm really excited to be here. This is going to be a pretty kind of informal talk. It's kind of like a thesis preparation type thing. It's just kind of a hodgepodge of everything I work on in healthcare and robustness and fairness. So please feel free to interrupt me as I go and ask whatever clarifying questions you have. Happy to talk through it, and we'll try to keep this spiffy. So today's talk, I'm going to be talking about how we can use artificial intelligence and more specifically natural language processing to improve health equity. So to begin, I want to start by putting this quote up on the wall, and I'll read it out loud. In the realm of healthcare, artificial intelligence serves as a powerful antidote to bias, paving the way for a future where every individual receives unbiased and unequal treatment. Does anyone know who said that? Or any guesses? Thank you, Rachel. You may leave now. I wouldn't expect you to get it because it was ChatGPT. And if you didn't see where I was going with that, -1 point. But basically, my point is that AI is clearly, ready to transform a lot of different industries. And healthcare is one that we see a lot of different opportunities. When we think of AI in healthcare, it actually already exists in various different forms, just not necessarily how we all look at it every day. So it's used in clinical decision-making, trying to automate different kinds of administrative tasks, and then on a different kind of scale, looking at public health surveillance. So for example, monitoring social media, understanding what's going on in the nation, monitoring flu and everything like that. And when we often think about AI in healthcare, we think about diagnosis and replacing doctors. I want to say first out, I think that's a terrible idea. We should not replace doctors, and we should not be trying to work toward that. However, I want to point out that there's a lot more we can do with AI that isn't necessarily focused on diagnosis and actually trying to be a doctor. And in particular, we're going to talk today about how we can use AI to fight against healthcare disparities. So today, we're going to talk through kind of 3 different points. So first, I'm going to provide an overview for those who aren't so familiar with how we can use AI in healthcare and fight disparities. Then I'm going to talk about how we typically think about using kind of defensive mechanisms to promote fairness and be able to deploy models in a way that are going to replace kind of biased physicians or biased kind of other processes in the healthcare system. And then finally, I'm going to talk about a different kind of opportunity or a different approach where we can instead say, let's try to attack existing healthcare disparities and try to elucidate them and then correct them. So that's the goal today. I'll begin with just kind of a broad overview. What is health equity? This is coming from the CDC. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. What does that really mean? It basically means that we all come from different backgrounds and have different privileges and disadvantages as we grow. And a big part of that is it affects the way we interact with the healthcare system and how we can maintain a good, healthy lifestyle. This is a map you've probably seen maybe at one point in time. So you don't have to look far to see health inequity in action. So this is looking at life expectancy in different Baltimore zip codes. You might have heard something like your zip code is your greatest predictor of your health in one way or another. And there's a lot of efforts that are more grassroots or more traditional where we try to correct these types of systemic inequalities, whether that's improving transportation to different clinics, looking at education campaigns, for example, things related to like teen pregnancy. And then, of course, like having job training, which can funnel then people into careers that have health insurance and everything with that. The main point I want to make is that artificial intelligence is not and should not be the solution. We should not be saying like, we're going to solve this. We're not, white knighting in here to say like, this is, the area we can solve. However, there are opportunities to use AI to help assist every one of these efforts that all these kinds of experts are undergoing. So in particular, there's two types of opportunities that I would like to highlight. So on the first, when we talk about having access to and quality of care, so providers that work in different low resource areas often have less time, less assistance, and they're exposed in general just to a very different type of daily clinical routine, whether it's, seeing sick visits or seeing very specific mental health conditions. They just don't have the time and the breadth to see, as much as they possibly could. So when someone comes to them and says, hey, I have this condition, they might not get the help they need. And that's unfortunate. However, AI has an opportunity to then essentially go in and then assist these providers and fill in the voids and augment everything that they're doing. The other place I see AI helping with health inequity is when we look at implicit bias and systemic discrimination. So we know that patients from marginalized communities are often treated differently by providers, both on a personal level, like how they interact between each other, and also on a clinical level. So they receive different treatments and have different health outcomes as a result. And you put that together, and these communities usually are less trusting of the healthcare system, and you have this kind of feedback loop. So there's an opportunity to use AI to start identifying these implicit biases and then starting to correct the behavior. And they kind of align with this conceptual framework we have for thinking about AI and health equity. So on the left here, we have what I would call like defensive tactics. So these are things that a lot of us think about, where is bias in data? How can we build a model that's going to behave fairly for different types of populations? And it's something that, you could go to any computational linguistics conference, and there's going to be, hundreds of papers that kind of mention something about this. On the other side, which is not talked about as much, is when we look at offensive tactics. So let's actually go out and try to find bias or find discrimination and then correct and modify it. And these are, efforts that we can undertake with experts in the field to then actually go implement kind of a system that's going to enact change. Thus far, as I kind of alluded to, a lot of the effort has been on the defensive side, especially from the computational perspective. We can think about math and we can think about data set bias really well. We don't really have the expertise usually with health equity to go towards the offense. So where we can really gain is by partnering with experts in these fields to actually go and try to measure, identify, and address these instances of social bias. So before I move on to the actual research, any questions about health equity or AI and health equity at all? Awesome. So I am one of the guilty people that has worked a lot on the defensive stuff, trying to understand biases in data, trying to understand how they affect models. Previously, when I gave this talk 2 years ago, it was all about looking at public health surveillance and mental health and why models really failed during the COVID pandemic. So I'm going to move on a little bit further in time. I'm no longer using logistic regression. I've moved up to using BERT models, so you're welcome. And we're going to talk a little bit about why clinical language modeling is difficult and what we're seeing when it comes to transferring to different clinical domains. And this is from a paper that we presented at Machine Learning for Health back in December. So the problem we're interested in is related to diabetic retinopathy. If you're not familiar with diabetic retinopathy, it's basically a condition that can arise when you are diabetic and you can start to lose vision in your eyes because new blood vessels form, essentially. It is not reversible, so once it happens, you might become potentially blind. And it's important to have regular kind of treatment and screening. Unfortunately, we know that like Black patients are less likely to follow up and to adhere to these types of regimens. And they're often just like left left to their own devices from the healthcare system. So it's really important that we're able to identify these kind of lapses in care. Unfortunately, a lot of the structured metadata that we could use to do this type of sensing is in ICD codes, which are not sensitive for this particular purpose. So the question is, can we build a system that's going to be able to look at the free text and clinical notes, extract phenotypes, and look at things like, oh, this patient has this condition with this severity in their left eye, and it happened 3 months ago, and therefore we want to be able to send a notification that says, come on into the clinic, we really need to see you to do screening and treatment. The more technical problem related to this is when we look at the clinical data landscape and clinical text in particular, there's basically all of public text data. There's what we consider clinical notes in the research community. And then about 90% of that is this one data set called MIMIC, which comes from Harvard, MIT, Brigham, like that cluster. And when we talk about clinical language modeling, we often talk about MIMIC. And it's really mimic language modeling is what we're starting to learn. Johan's doing work on this too, trying to train T0 and T5 models for the clinical domain. And it's basically the same thing we're seeing across a variety of different tasks. So this is the kind of question is like, are these clinical language models going to transfer to something like ophthalmology, which is a very, very different domain than mimic, which is actually like intensive care units, emergency departments, different patient population. It's coming from Boston, whereas we're looking at Baltimore, very different patient population. We want to understand, like, are these clinical language models actually robust? There was a recent paper that came out last year that basically kind of looked at this, and they said, like, the question was, do we actually need clinical language models? This is given all the hype of, GPT-4 and GPT-3. Or can we start to, use these kind of non-clinical models for clinical purposes? And they did a number of different experiments and said, like, yeah, clinical language models are still really important. And they showed, like, they still outperform GPT models in a variety of different areas and, like, non-clinical BERT models and things like that. However, they evaluated on 3 data sets that come from Mimic. They trained their model on Mimic. And this is basically everything that's done usually in this community. It's as if you were doing a Wikipedia-based task and you trained everything on Wikipedia. Your model is like some kind of lead. It's there. It's basically been trained for that specific domain or that specific data set. And we want to understand like whether or not this is actually the case. So looking at the type of data we're working with here, this is kind of an example of a synthetic clinical note. Here you have on the top different kind of ICD codes. So this is what you would use typically without looking at text, which says what a patient has. This is like a billing code you could imagine. They are not always coded for like specific eyes. They're often just like a generic, like this patient has diabetic retinopathy. It doesn't say if it's current, what eye it is, or anything like that. Then you have a variety of different sections in the note. You have what's called a problem list, where basically a provider will put down one of these ICD codes and write a lot about what they did during the encounter, during the office visit, and what their plan is moving forward. And we want to be able to extract concepts from these notes that are relevant to diabetic retinopathy, and then do kind of classification on things like laterality, severity, and temporality. And be able to essentially augment those ICD codes. So we developed this data set. It took about a year. Annotating clinical data is incredibly hard. And one of the main reasons I would say, if you like yourself, don't go into working on clinical data. But basically, we have a massive data set. I say massive, it's 690,000 different unlabeled notes. And then in terms of an annotated data set, 6,565 spans. So that's all we have. But it took forever to get. And we have 14 different classification tasks, things like trying to predict laterality for specific conditions, trying to understand whether or not a procedure is happening on the left or the right eye, things like that. We're using a pretty simple modeling architecture in this case. We're trying to understand on the performance of BERT more or less. So we're trying to mitigate any of the other potential confounds. So it's just a BERT encoder that takes in the sentence and then is essentially doing token span classification on a mean pooled representation of these clinical concepts. The concepts themselves, they're coming from a regular expression-based system that's like high recall. So the idea is do high recall regular expressions to find these potential concepts, classify whether or not they're valid, and then also understand whether or not they have all these different attributes associated with them. We look at a variety of different experiments, trying different types of BERT encoders, which have been pre-trained on different amounts of data and different types of data. So looking, for example, at BERT base, which is trained on web data. We look at clinical BERT, which has been trained on mimic data. And then we also experiment with training a BERT model completely from scratch on our 690,000 nodes. And there's some other kind of experiments we do with task fine-tuning as well. The main kind of takeaways kind of can be broken down into 3 points. So in the plot here, what you're seeing here is performance essentially as a function of the encoder, whether you're doing task fine-tuning, and how much training data you have for pre-training. And what we see is that these clinical BERT models really aren't performing that much better than a regular web-based BERT model. And this is really interesting because that previous paper said, like, yeah, you really need these clinical models. And we just showed, like, no, apparently they don't transfer to ophthalmology, like, you say, so that's one kind of main result. The other one is that you see when you look at this kind of curve going from the 0 to the large in terms of pre-training sample size, you have to do some form of domain adaptation. And that's really important in the healthcare space. We often try to think about, like, we want to train a big general model, right? We're going to have a general clinical language model. We want to have a general model for all of language. But you still need to have this type of domain adaptation because every population is going to be different. And it makes a big difference in a mission kind of critical or performance critical domain like healthcare. And then not kind of shown on here, but we also saw that a domain specific vocabulary does really help. So it's important. These are all kind of results, but it was kind of our surprise given that recent paper and all the hype it got. So as it has different implications for AI and health equity. The first one, not all clinical data is the same. So we want to really highlight this to the community to not just be treating every mimic result as a general clinical result. And it's also just really important to think that there's different patient populations around the world, around the country, even around the city. And it's important to be cognizant of these when we're trying to deploy different AI systems for different purposes. And then the other one, which is kind of more technical, but this kind of idea about prioritizing domain adaptation over generalization, I think it's, if you were going to come work in the clinical space, trying to figure out how we can use non-clinical language models, which have been trained on a lot more data and always will be trained on a lot more data than the clinical data models, I think is the way to go. I kind of think of it as you want to teach the model language, right? And then you teach it about medicine. You don't want to just say, okay, from birth, go learn everything to become a doctor, right? Like that doesn't necessarily make sense because now once you have to go do something else, you fail. So that's kind of where we're at right now. A lot of the defensive kind of concepts we're talking about for health equity. All right, so before I move on to the more offensive side, any questions about that work? Carlos?
How does the takeaway of referring to do domain transfer align with the difference that you found in using domain specific vocabularies? Because usually the vocabulary is stuck in the model. So
yeah, I think it's a great point. So I think there is work, right, that's been done on trying to adapt vocabularies and adapt tokenizers. So that's like one angle that we could potentially go. It also might mean that you might just be better off training your model from scratch, like a small model in some way, or doing some other kind of adaptation. To be completely honest, this is out of my realm, figuring out how to actually make the models do specific things. So I encourage you all to think about, how you might make an impact there. Cool. All right, so now we're going to talk about the different type of approach where we look at trying to go on the offense, trying to identify cases of bias and then actually elucidate them to healthcare providers. So this is all coming from an ACL paper that came out last year. So the problem here is we're looking at stigmatizing language. When we think about stigmatizing language in the context of healthcare, we often think of things like addict, substance abuse, crazy, junkie. These are a lot to do with like different type of mental health terms. And you might have seen like blog posts saying like, don't use this word, use X word. However, in the medical record, there's other forms of stigmatizing language that are usually more covert. You don't have doctors calling a patient idiot in the note, right? They're not saying things like that. They do everything in more subtle ways. And we want to be able to understand how they're doing this and if they're doing it disproportionately across different demographics. This is really important because we know that people who experience discrimination, which is more frequently Black patients, have lower levels of adherence to their treatment plans, they have lower trust in their healthcare providers, and they're more likely to delay care that's necessary. And this is really kind of time critical because the recent 21st Century Cures Act says you now have you have access to your medical records. You can go look and see what a doctor's written about you. So there's kind of more timeliness or more time sensitivity than normal when it comes to trying to identify these cases of bias. Looking at data, so here's Mimic again. It's a different version of Mimic, but Mimic nonetheless, as well as data from Johns Hopkins. So we're looking basically at different types of clinical notes across different specialties. So at Hopkins, it's looking at internal medicine, emergency medicine, peds, OB-GYN, and general surgery. Mimic, it's all from discharge notes related to the intensive care units in Boston. So what does the stigmatizing language actually look like, and what are we trying to classify? So this is one of the kind of subclasses when we talk about like credibility and obstinacy. So telling or like saying the patient is difficult, they're like annoying, or on the other end of the spectrum, you don't believe what they're saying. So some examples here are on the right. And then there's plenty of cases as well where like words that are often stigmatizing are not actually used in a stigmatizing way. So we want to be able to identify that. Here's another kind of class of stigmatizing language, looking at compliance. So there are different ways you can talk about a patient adhering to different medication regimens. You don't want to, for example, say like they complied with my orders, right? Like that's very kind of patriarchal. So it's important to have this different type of usage of language when we're talking about medication and treatment adherence. And then the last one is descriptors of appearance and behavior. And this is more the most kind of overt instances of stigmatizing language, like saying the patient is aggressive, saying they're malingering, meaning they're like looking basically for drugs or something like that. That's why they're in the ED. We built this system. It's a pretty simple system. Like I said, I don't do anything super complex. Basically, we look at the clinical note, we extract words that we think are stigmatizing based on domain expertise. We pass those words alongside their context into BERT, and then we make a prediction about whether or not it's stigmatizing, and then if so, which type of stigma it is. Performance-wise, the plot on the left, numbers are good, BERT is good. Better than logistic regression. I'll eat my words that I probably said 3 words ago about never using BERT. It performs very well. What's kind of interesting here is on the right, we start to look at projections of those kind of the keyword representations. And what you see is that the model is essentially having global representations of the label space, which makes sense. However, it's doing this very kind of local clustering of the actual words themselves. And this is problematic because now if we say, okay, oh no, we thought of a different stigmatizing keyword, we want to go add it into the model, it's likely that the model won't necessarily know what to do with it. So this is kind of one of those like problem areas that we identified early on, like this could be a problem for our system if we're not careful with it. The other thing we did was looked at how models trained on each of our data sets performed on the other across the different tasks. And as you might expect, there's transfer loss that occurs between each case. But the bigger question is like, why does this happen? There's kind of 2 main reasons. The first is looking at covariance shift. So the patient population in Mimic is very different, which we learned. So there's a lot of psych patients. And there are a lot of words that are used in a stigmatizing way in non-psych units, which are just normal in the psych. So if you said like the patient is angry, like that's a completely normal, fine like term in psychology and psychiatry, but not so much when it's used in emergency medicine. The other issue that shows up is that you have this different kind of prior shift where the distribution of labels is conditioned differently for the words that we have in Mimic versus we have for the Johns Hopkins data. So this was an interesting experiment where we really had to probe and look and understand why these models might fail if we try to deploy them at scale. So takeaways here. One, these offensive tactics we're talking about, like this system has potential, and now we're going forward to try to deploy it at scale across 90 million notes and trying to measure different disparities at Johns Hopkins, and then eventually showcase these disparities to providers so that they can start to correct their behavior. But it is still important to have this kind of defensive mindset and understand like how can we create the most robust system. We're not just trying to go on the offense for the sake of going on the offense. And then the other one is that simple NLP approaches go a long way. As you saw, the model and like the system design, pretty straightforward, regular expressions and like a classifier. That's all it was. And this adds a monumental kind of improvement in what was previously done just looking at like keyword matching. And people in clinical medicine love this. It's more than like they are able to do often by themselves. So there's a lot of impact to be had. And I think kind of to go further off of that, this is a kind of a visual that was presented at that Machine Learning for Health conference from Charles Delahunt. But when we look at the machine learning community, and if you have this graph of like being more effective or less effective in terms of the healthcare problem, and then being more technical and less technical, most machine learning papers end up very much in that kind of like angle towards the more technical with like no effectiveness. Where in contrast, I like this example that he gave, Gatorade, right, which is sugar and salt and water, basically, has helped cure dehydration in children for a number of different developing countries. Very, very simple. If you tried to write a paper right now on Gatorade, you probably wouldn't get it accepted. 20 years ago, it was massive, right? But either way, the point is that you don't need to do something complex in this space, technically, to have a big impact. And it's not necessarily what we should be chasing. So with that, that's everything I have. I'm happy to answer questions or just talk to everyone afterwards about my thoughts about clinical NLP.
Questions?
Carlos?
For the stigmatizing keywords, I'm assuming there was some development said of, okay, this is what we think are the stigmatizing words. There are efforts to find new stigmatizing, like lexicon, I guess.
Yeah.
Where maybe you didn't fix it.
Absolutely. So Aya, who is maybe online, but is not here, is worked a lot on that. Looking at, for example, trying to do like semantic search basically for expanding that kind of lexicon. We're looking now at trying to use GPT models to discover it and not necessarily rely on keywords in particular. We think that's a major limitation and something we're trying to address. It's incredibly hard to give GPT models HIPAA compliant data. So we still haven't been able to do that. So it's something we're working on. But there is a lot more to do. The other thing I'll say is that there's more types of stigmatizing language. Common examples include quotations. So you might see in a clinical note, a doctor will quote a patient because they use a different like vernacular or dialect that they think is like worth highlighting, but it's more kind of like a joke at the patient's expense. So like that's one type of potential stigmatization. But there's also like positive forms, and that's something I didn't really highlight as much, but like how the fact that like a provider might use positive language toward like a certain patient population more than they would for another is also worth highlighting.
Your thoughts of where some of these models might generalize. So you talked about some examples of how if you train on this data and it it's a different setting on the clinical side, it's a different city, different hospital system, and so it doesn't generalize very well. But it seems like logistically difficult to train a new model for every subsection of every hospital system. And so, what do you think is the solution there? Are there some things that actually do generalize better than others? And, what if you just train the model on everything that might not get some of this?
It's a great question. So I think in terms of what has the best chance of working, it seems like clinical specialty, like if you had a model for ophthalmology, it seems like it will be better at other ophthalmology because the way the training for physicians is, like you can go from one ophthalmology department to another and they will adopt like similar practices. They see similar types of cases on the day-to-day. And the same with like emergency medicine, like there's different practices from that angle where I think you could see generalization. I think you still have to do like some form of unsupervised adaptation, which is really what we focus on. And I think that is doable for a lot of different healthcare places in scaling up. And then the second point, remind me, second question was?
I guess the second thought was, I can believe if you train the model on one data set and switch to another, it might not work that well, but what if you just train it on?
Yeah, that's a great point. So we talked about this, and this is one of the, I guess, debates about like large language models in general. Like if you train on everything, is anything ever out of distribution? Truthfully, like there's always temporality, right? So like what happens in clinical space evolves very quickly. So if you train a model today, it might technically be outdated in some way along some axes tomorrow. So I don't necessarily know if it will ever be able to just like train on everything and hope for the best. And I think then there's also just like logistical constraints with that. Like Hawkins doesn't share data. It has to be anonymous. Like it's kind of a mess. But I would love eventually to see someone train like a clinical language model on like 20 different hospitals from all different places and see if it actually solves the problem. And we just need to figure out a different way to do it securely.
Yeah. You ever see any artifacts or pieces of resilience to mistakes or false identification biases?
So in terms of resilience, I'll say one thing that does come up a lot is even though we're focusing on classifying a single keyword in a sentence, if there are words around it that are like positive, but the instance of the keyword we care about in that specific case is like negative, it will get distracted easily by what's going on in the context. So if it's like the patient is a charming young lady, poor historian, right? Like it will get distracted by the charming part still and say like, okay, they're actually talking about the patient in a positive way. It doesn't happen super often, but that is something that we do see.
Well, regarding your last slide, I liked it a lot because it's true that when you work with, well, also when you work with medical data, you don't have that much data in which you really can do so many complicated things. But also you don't sometimes talk to the doctors to ask them what they really need. And you just try to do is something I discuss a lot with the students. Just try to do whatever you think. It's very interesting, but then they don't need it for anything. And it doesn't make any sense. So this is very, very appropriate. I like it. So I have a question regarding the data. Were you involved in the IRB process to get all of this data from the hospital?
Yes. Yeah.
How long did it take? I'm curious.
So the stigmatizing language data, that so the first part was easy because it was pre-2017. So it was like a horde of data that had been collected. The recent acquisition of 90 million records took us about a year to get, and we're still sifting through it because it's a lot of a mess, basically. So there's like the actual logistical troubles trying to get access to the data and then actually be able to query it effectively and all that. Then there's the more kind of like legal, I guess, issues, which are also challenging, but I think we have systems in place now, from what I can tell at the hospital, that are moving toward being able to give us access to data. The ophthalmology data was the same way. Like we got really lucky in that the data was collected, or like the source data was collected previously, and all we had to do was do all the annotation and then like go from there.
Okay,
Yeah.
so it was collected for another IRB probably.
Yeah.
They just gave you access to this IRB. So
Or yeah.
Relatively less than. Okay.
Yeah.
Yeah, because that's getting permissions to have access to this is what I see one of the more challenging things that as for someone working in medical applications, it's probably some of the things that most people don't face. You just have a link to a data set that is somewhere and your advisor tells you use this data and do your experiments, and just having to get access to the data is all the work.
Yeah.
Sometimes too.
One thing, a good example of this is if we look at who knows how we annotated this data? If you guessed Microsoft Excel, you would be correct. If you guess anything else, you would be incorrect. This was like a limitation, was we couldn't even get annotation software that was HIPAA compliant to run on Hopkins servers, and had to do everything instead in Safe Desktop. These are like data validation cells. I was very proud of how they came out, but I would not recommend anyone ever do this if they don't have to.
So you have to work for annotation all the time in Safe Desktop.
Yeah.
Well, the good thing is that you can use Safe Desktop anywhere. Like, I mean,
Yeah.
you could do it from New York.
It is
you have
true.
to come here to do it.
Yeah.
That's good.
It could be worse.
Yeah. Yeah.
I have a question about your last slide.
Yeah. What's the question?
So it seems that the people are working on more effective and less technical approaches, right? So do you have like any thought on how to move like the more technical papers towards more effective instead of being like more technical and less effective?
Yeah, it's a great question. So I agree with this point that this speaker had brought up, but I think a big part of it is incentive structure. For reviewing, for example, like if you go to NeurIPS and someone submits a paper on logistic regression, but it has a massive health outcome or like implication, it probably won't get in because it's not technical, right? So they're like the Machine Learning for Health conference, for example, and I think we're starting to see it maybe with other conferences as well, starting to put more into what is accomplished and what the effect is, as opposed to what the techniques are. Because I think if you are judging based on that full kind of spectrum, you can start to see better diversity. If you really want to, you can go to like a non-ACL journal or like a non-machine learning kind of conference and find like these effective papers, when people are talking about healthcare applications. Of course, then you look at the incentive structure and you go to get tenure, and it's like, why did you submit here? It's like, oh, because they care about what I do. Like it's all, I think, kind of the external stuff right now.
Yeah, we maybe need to publish more in medical journals because they are the ones who really see the potential on what can help. But
yeah, 100%.